Good afternoon. Welcome to Keeping You in the Know in 2023. As part of our LCI Survivorship series, today our presentation will be on treatment for breast cancer from a physical therapist perspective. We're very grateful to have you all with us today and to learn from one of our Gloria Drummond physical therapists, Anita Parando. At the Lynn Cancer Institute, we believe that education, prevention, screening, and early detection, a variety of treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, Anita's bio was sent to you by email. And during her presentation, we invite you to please take notes. And if you have a question, put it in the chat box or the Q&A box. Anita will not be able to see you during her presentation, but there will be time at the end for her to answer any questions that you might have. And now we're very happy to welcome you to the Lynn Cancer Institute and to introduce Anita Parando, physical therapist. Thank you, Anita.
Thank you so much, Jan, and I'm really delighted to be able to give this presentation. So the goals of this presentation are to introduce you to oncology physical therapy, to discuss the current and historic role of physical therapy in cancer care, to talk a little bit about what we assess through active treatment and inter-survivorship, and how physical therapy can ameliorate some of the consequences of cancer and cancer treatment. So my name is Anita Parando. I am a specialty physical therapist. I have advanced training in oncology, and I'm with the lymphedema department at the Gloria Drummond Outpatient Physical Rehabilitation Institute in Boca Raton, and also at Bethesda Hospital East in Boynton Beach. Our oncology lymphedema department is well established. We have 5 physical therapists and 1 exercise physiologist who has advanced training in cancer and exercise. We are advanced clinicians, and we hold specialized certifications in breast cancer, head and neck cancer rehab, and lymphedema. The majority of our patients have been or are currently undergoing treatment for breast cancer. We provide education and treatment for a number of consequences of cancer treatment, which includes pain, decreased shoulder range of motion, scar tissue, seroma, axillary cording, fibrosis, deconditioning, implant issues, and lymphedema, to name a few. We treat patients immediately after their surgery while they're undergoing treatment, as well as patients who are long past their treatment but may have lingering issues. This is our team at Boca Raton. And some breast cancer statistics. Why is physical therapy getting more involved in breast cancer care? Because of survival, more favorable survival statistics. Patients are living longer due to early detection and treatment. So in the past, the main components of cancer care were surgery, chemotherapy, and radiation. Physical therapy is now and will continue to have an increased role in cancer care. And one example is fatigue. Fatigue can persist in 25% of cancer survivors years after the treatment has ended, impacting quality of life. As physical therapists, our role is to increase a patient's functioning. So we are the exercise experts and the quality of life experts. So board certification. Physical therapists have board certification the same way other medical professions do. So it is very advanced training. Oncology is a very recent board certification. It became a certification in 2010. And as of the last time they took statistics in June of 2020, there were 105 board certified specialists in oncology physical therapy. This is as compared to 17,000 specialists in orthopedic physical therapy, 3,000 in neuro, and 550 in women's health. So this is a growing area in physical therapy. Physical therapists are getting very interested in working with this population. So what are the specific rehabilitation needs? when do we come in to work with patients? We come in preventatively. So before development of the disability, many facilities have pre-surgical assessments and education. Restorative, that's when most people think of physical therapy. Post-surgically, if a patient is having some disability or some issue, we restore them to their pre-morbid status. Supportive, in the case of ongoing disease, we help to mitigate decline and improve function and help patients to maintain their highest level of function for as long as possible. And we also offer palliative care. So we maintain function, comfort, quality of life in the face of progression of disease. So with surgeries, some of the surgeries that we see that we deal with, sentinel lymph node biopsy versus axillary lymph node dissection. So with the sentinel lymph node biopsy, that's a relatively recent procedure. It just started in the 1990s, and it is because some physicians recognized that the lymphatic system, which is the system that drains our bodies of debris, it's a part of our immune system. The lymphatic system is very organized. So they discovered that in the case of the breast, if they can identify the first couple of lymph nodes that are draining the breast, and they can identify that there's no cancer in those lymph nodes, it is very unlikely that the cancer will have spread to other deeper lymph nodes. So during surgery, or prior to surgery, they'll inject a tracer so that during surgery, they're able to remove the first couple of lymph nodes and send them to pathology and see whether or not there's cancer in those lymph nodes. If there's no cancer in the lymph nodes, then the system is, lymphatic system is not disrupted very much. If they do see cancer, they will have to do an axillary lymph node dissection, which you can see in the second picture is more invasive. So they're removing a lot more lymph nodes, many more lymph nodes, and they're disrupting the system more. We, as physical therapists, like to see every patient that has an axillary lymph node dissection because, again, as you can see, it's a much bigger surgery, and it can impact the lymphatic system, it can impact lymphedema, it can impact shoulder range. So we do like to see those patients as soon as possible. Lumpectomy versus mastectomy. The lumpectomy is a less invasive procedure versus the mastectomy, but each one causes incisional scar tissue. So we do like to work to make the incisions, the scar tissue, more supple. Incisions, scar tissues have to be able to move. And every time you have a surgery, anytime you disrupt the connective tissue, disrupt the skin, you have the potential to cause tissue restrictions. Reconstruction. Many of our patients there are many different types of reconstructions. Most involve multiple surgeries. We will help patients with the aftercare of their reconstructive surgery. Some patients go for no reconstruction or even deconstruction, and we help those patients attain the most favorable outcome. So this is just a diagram of where there might be incisions with these different types of reconstructive surgeries. And again, I just put this up here because we do like to make sure that incisions, scar tissue is supple. That's very important for maintaining your range of motion and maintaining the best possible function. So after surgery, what are some of the things that we assess? So we rarely see patients prior to 3 weeks after the surgery because patients have drains, patients have movement restrictions, usually they're healing. We might see a patient 3 to 4 weeks after the surgery if the surgeon identifies that perhaps they're having a problem with range of motion or with lymphedema or something. So one thing that we look at are seromas. Seromas are the accumulation of fluid that's not uncommon in a place where tissue has been removed. Sometimes seromas need to be drained. Sometimes they need to be drained multiple times. When we see a patient with a seroma, we will often fabricate or recommend some kind of compression garment, because if you can limit the space, the potential space that's there, the body will drain that fluid naturally and eliminate it from the system. A couple other things that we look at when the surgeons do particularly axillary lymph node dissections, there are a couple of nerves that can be touched or tugged. So often patients will wind up with a condition called scapular winging. Some of the muscles will be a little weak. This is reversible. It is usually repairs itself over time, but we will see weakness of those muscles. We want to work with those muscles to help get them stronger, to get those nerves firing a little bit better. Patients also often complain of numbness in the armpit, in the arm, in the lateral chest. This is also due to a touching of one of the nerves. We really encourage patients in areas where they're numb to palpate those areas, to touch those areas, because that's going to help the nerves regenerate. It's going to help the nerves know where to go, how to regenerate, to get that sensation back. Axillary web syndrome and cording, that's a big one that we deal with. Sentinel lymph node dissection, about 40% of the patients develop cording. Axillary lymph node dissection, 81% of the patients develop cording. And cording it's a strange thing. You know, they still don't know exactly what it is. Some people believe that it is fibrosed lymphatic vessels. Some people believe that it's the connective tissue around those lymphatic vessels, but they're not quite sure what it is. Women with a low BMI, thin women, oddly, are more likely to develop axillary cording. About 50% of the time, you cannot see the cording. So women will go to their doctor. Oh, and men and women both get breast cancer, but because we primarily see women, I'm just going to address this towards women and she and her. So what usually happens is she'll go to her doctor and she'll say, my arm feels funny. I can't raise it. It feels restricted. It's not a painful condition, but the arm feels restricted. And sometimes the doctor will be able to see the cording and send them for physical therapy. Sometimes you can't see the cording. Every patient who comes to me with a shoulder restriction, I will treat as if there's cording there. There are special techniques that you do to stretch the cords. Sometimes the cords snap. That's not a bad thing. Usually the woman gets relief right after they snap. But cording is something that's best caught early, because the sooner you can catch it, the cords are thin, they're small, they're easy to manipulate. Reconstruction, again, we help women if they are having any implant issues. Some implants need to be mobilized, some don't need to be mobilized. Sometimes there's tightness around the implant, so we work with women, again, to get the most favorable outcome with the reconstruction. Tissue adhesions, again, tissue adhesions can come from the surgical incisions. They can also come from just tightness. Sometimes post-surgically, women might guard the area. They might guard the area of the axilla, the armpit, the breast. They might draw the arm in, and the body very quickly adopts this posture and starts to tighten up the tissue. So we address adhesions and postural changes, impaired shoulder function, and also pain. Sometimes just the trauma of the surgery itself can cause pain. And again, sometimes posture. If your posture is, if you're guarding, all of these tissues will contract and will cause pain. So we help with that as well. Desensitization and touch aversion. Again, we really encourage women to touch their incisions, to mobilize their incisions, and to touch areas that are numb. Again, it helps the nerves to regenerate. And also, it always surprises me how many women have discovered their own cancer by the self-examination. So it is important, because you have had surgery to the area, to know sort of what the new normal is, so that you can feel if something is different. Lymphedema and BMI and body composition, those are two biggies for us. So with lymphedema is the disruption of the lymphatic vessels. due to lymph node dissection or sentinel lymph node dissection or axillary lymph node dissection. Here at Boca Hospital, we use a machine called bioimpedance to monitor for lymphedema. So we have a very aggressive lymphedema surveillance program here. So on the day of surgery, she will go in and have her stand on a machine, and she'll have the fluid in her arm measured, and that will give us a baseline measurement. Okay, so this machine monitors her for subclinical lymphedema. Lymphedema is another condition that needs to be caught as early as possible for best outcome. Lymphedema can even be reversed if we catch it early enough. So we're pretty aggressive about that. So she gets baseline measurements on the day of the surgery. If she comes to us for physical therapy, we have a machine here, so we can also monitor for lymphedema during treatment. Also at Lynn Cancer Institute, the dietitians have a machine there. And all of these machines are connected. So I can see what the baseline measurements are. The dietitians can see what our measurements are. And this way, there are multiple people monitoring for lymphedema. This machine also looks at body composition. So it looks at BMI, which is your body mass index, and body composition, which is your muscle to fat ratio. It's being recognized more and more the importance of body composition for numerous reasons, but for, again, for favorable outcomes, for reducing risk of recurrence and reducing other comorbidities. So progressive institutions are looking at body composition very closely. There are many thought leaders who believe that body composition and diet should be looked at, and patients should be educated about the importance of body composition and diet from the moment of diagnosis. So the American College of Sports Medicine guidelines for exercise. Exercise is important for reduction of recurrence, improve treatment tolerance, reduce fatigue, manage weight gain while on estrogen blockers, which is a common side effect of the estrogen blockers. So radiation therapy. Radiation therapy works by damaging the DNA molecules of cells and cancer cells so that they can grow or reproduce. But radiation therapy does not discriminate. So it changes the cells of everything that it touches. So it changes the cells of the skin, the muscles, connective tissue, joints, nerves, bone, blood, and lymphatic vessels. And radiation continues to act for a long time. It continues to do its thing for about 2 years. So we like to see patients who've had axillary lymph node dissection and radiation. We like to see 100% of those patients, because we want to get them into treatment as soon as possible, and educate patients on the importance of stretching, the late effects of radiation, how radiation therapy will impact their function in the future. One thing that we will let patients know is that they can, while they're going through radiation, they can develop some transient lymphedema. So we might ask them to wear a compression sleeve during therapy. Also during radiation, we can address joint stiffness through joint mobilization, and we can also work on some of that tissue that's being affected by the radiation that's developing fibrosis or getting hard. So late effects of radiation that can occur 6 months to 2 years or longer. Because the radiation affects the tissues of the skin and the connective tissue, you can get a contracture of the breast, you can get tissue fibrosis, or you can develop lymphedema. So we work with patients to ensure that they maintain their range of motion, especially their shoulder range of motion, and keep the tissue of their skin and connective tissue as healthy as possible. What we have seen in the past is women who have radiation therapy, stretching for life is a thing that has to happen. I mean, we all should be stretching as we get older. But because of the way radiation works, and this happens slowly over time, she'll start to, her shoulders will start to protract, her skin will start to get tight, and she'll start to lose some of the range of motion in her shoulder. It happens very insidiously. So this is why we like to see these patients as soon as possible to get them into a good stretching program and to reinforce the importance of stretching, lifetime stretching. Exercise during radiation. So the biggest side effect that we see with radiation, besides the tissue changes, is fatigue. And that usually starts at about week 3. Exercise has been shown to cut the fatigue that occurs with radiation in half. And I've had patients say, Anita, the last thing that I want to hear when I'm going through my radiation treatment is that I have to exercise. But it is important for them to know that exercise will help them to feel better and will even help them to be able to continue the treatment. And this is one reason that thought leaders want education in exercise and diet to begin at the moment of diagnosis, before patients start to feel the effects of their treatment. So chemotherapy is the systemic treatment of cancer with anti-cancer drugs, and it attacks the quickly dividing cells. There are many side effects of chemotherapy. I don't know if anybody was able to sit in on the panel discussion, and Dr. Tay and Dr. McDonald discussed many of the side effects of chemotherapy, of anti-estrogen medication, of radiation. And the one thing that seemed to help with every side effect is exercise. So neuropathy, weakness, and fatigue are 3 things that physical therapy can help with. We can't cure the neuropathy at the moment. There's a lot of research done on that, but there isn't a cure for it. But we can help with balance issues to prevent falls. We can help with weakness, helping a patient to stay as strong as possible, and with fatigue. Anti-estrogen medications side effects. Some women don't have many side effects at all. Some have significant side effects. Arthralgias and joint pain are common, as are hot flashes. Weight gain is big with the anti-estrogen medications. And again, this is why we like to get patients into therapy or with an exercise physiologist as soon as possible, so that we can help to mitigate that weight gain, so we can help to decrease the weight that's put on, because we do recognize that obesity is related to recurrence. And exercise during chemotherapy, again, this is something that patients tell me this is the last thing that they want to hear, but exercise has been shown to help spread cancer drugs throughout the body, can stimulate the immune system, can reduce sarcopenia, and improve chemotherapy completion rate. So again, if we can get her to start exercising and moving from the moment of diagnosis, all of her treatment outcomes are improved. Sarcopenia is the medical term for muscle loss or for muscle wasting. Sarcopenia is something that happens with age. It's a natural occurrence, but patients with cancer and who are recovering from cancer are at much higher risk for sarcopenia. As high as 79% of the patients have been shown to have sarcopenia. So anything that we can do to improve our muscle mass and our muscle to fat ratio is important for our overall health and for maintaining healthy function as long as possible. So again, some things in survivorship that I'd like to talk about. Again, the importance of body composition. So again, not only do we have the ability to look at somebody's body composition here at Gloria Drummond, but at Lynn Cancer Institute, the dietitians can also look at body composition. And what's really nice about these institutions working together within Boca Hospital is that the dietitians can look at body composition, and they can make dietary recommendations based on what the patient's goals are. Does the patient need to lose lose weight? Do they need to lose fat? Do they need to improve their cardiovascular health? Do they need to improve their strength? And those dietitians can make appropriate referrals to physical therapy. When we evaluate patients, we can also make referrals to the dietitians. So there's a wonderful program at Lynn Cancer Institute where patients can see dietitians for up to a year after they're finished with their treatment. So that's a terrific service that's offered here. And again, surviving breast cancer often puts women at an increased risk for chronic diseases due to unfavorable changes in body composition. Weight gain is common. And as we know, obesity and weight gain can adversely affect the risk of breast cancer recurrence and death. In addition, excess fat places patients with breast cancer at higher risk for lymphedema. Lymphedema can be significantly improved when you reduce your fat and have a healthier body composition. Exercise also reduced breast cancer recurrence and mortality by 40%, whereas weight gain of more than 10% after diagnosis appears associated with an increased mortality risk. So that's another reason that we also have exercise physiologists in the picture. And our exercise physiologist has a specialization in oncology and exercise because, these, healthy BMI, healthy body composition is important for so many reasons, for so many positive outcomes. So patients are at a lifelong risk for developing lymphedema, but it's most likely will develop within the first 2 years. We have a very strong lymphedema surveillance program. Again, this is done, lymphedema surveillance is done pre-surgically for baseline measurements, while in therapy, and at Lynn Cancer Institute when patients are visiting with dietitians or seeing their oncologists. And the earlier we can treat lymphedema, the better. So the machine that we use is bioimpedance. It's also called a SOZO. And what it does is it measures subclinical lymphedema. So it's lymphedema before it even appears, before you even notice it. So, and it detects very, very small differences in fluid in the limb that's at risk. So we can put a patient on the SOZO, see that she's maybe developing some subclinical lymphedema and get her into treatment right away. And again, tissue changes that occur with radiation therapy, we will prescribe a program of stretching and strengthening. It's recommended for life. And women also experience a sense of abandonment after intensive treatment is over. And they often wonder, what can I do to live the healthiest life that I can? There are plenty of support groups. Lynn Cancer Institute has a number of support groups, has a great team of social workers that can provide reassurance that they can return to therapy if they need to. So here at BOCA, we have a whole team of allied health professionals who are here to support women through every stage of their treatment and afterwards. Here are some resources. This is a great book, Moving Through Cancer. It has compiled the latest research on exercise during the different stages of treatment, and it gives recommendations on dosages, what types of exercises a person should do. So this is just a great resource for everyone, any person that is being treated for cancer. And these are references. And does anybody have any questions?
I don't see any questions. I'm looking in the QA box and the chat box. You covered everything so well. I think this was so informative. I would imagine people will probably have questions once they digest everything that you gave to us. Because, I mean, Robin said, thank you, great information. And I agree on that. It's like so many things that I know I'm not aware of. And it's just so good to educate all of us so that our patients are aware of all the amazing treatment options that we have here at our hospital, and how beautifully our teams all work together just to help the whole person.
Yeah, this presentation was originally to the physical therapy department so that our department knows what we do. And it was originally an hour and a half long. So if I condense too much or talk too quickly, it's because I did not want to go on for an hour and a half to have everybody, have to endure that. But yeah, there's so much that's offered here in allied health to help women and men, to help anybody recovering from cancer really lead their best quality of life. The days of saying that a patient should just rest, should not move, should not exercise are over, as are the days of saying, well, we cured you of your cancer, without considering, well, this person would like to hold their grandchild in 20 years. This person does not want to have a big, gone are those days, and we really, really are supporting women to have the best quality of life that they can.
Yeah, well, that's, perfectly evident from everything that you presented to us and what we offer here at the Lynn Cancer Institute. Not only clinically, which we all know how that is, but through our support services. I see something else in the chat box. Let me see what that is. Yeah, someone else said it was a lot of information, and she thanks you for all that you do. It's very amazing. And our Lynn Cancer Institute is multimodality, and definitely we can see that physical therapy is a definite component of that. And so thank you for sharing that with us, Anita. And for everyone on the presentation, as with all of our lectures, this will be recorded. So if you want to go back and gather information or share it with people in your department, your family or friends, anyone that you think would benefit from this education, Lee is out this week, but when she comes back next week, she will put it together. And when she sends out the evaluation form, which will be a little bit later because she's not here until next week, she'll include the link so that you can review the presentation. And we ask you that you please send in the evaluation. It's always nice for the speaker to see the feedback. And it's good for us to see if you have any recommendations on topics that you would like to hear about. So we appreciate everyone who has taken time during their lunch hour today to join us. And we hope to see you on October 25th when we will have a presentation from Brandy Hyatt, our oncology dietitian, and it will be nutrition and breast cancer as part of our monthly nutrition series. So thank you, Anita. We really appreciate very much you sharing with us. And maybe we can do another one in the future where all the other hours worth of education can be shared. And
thank you so much, Jen.
Okay, thank you. And thank you everyone for joining us. Have a great afternoon.